Hi, Philip. I'm David Playford. I'm a cardiologist in Perth in Western Australia. I'm an echocardiologist, imaging particularly, also cardiac CT, professor of cardiology at the University of Notre Dame, and I've been very involved in big data research, echocardiography particularly.
Great, thank you. Well, thanks for being here. I've got a first question for you. Could you briefly explain for the audience how EchoSolve might get used in cardiology practice?
EchoSolve is intended to take all of the data the way I would look at data as a cardiologist. So thinking about maybe the way that I would normally report, and I think most echo people would report in the same sort of way. What I normally do is look at the whole echo. So I'm looking at all the data. So not just a single view, although obviously a single view is helpful, but I'm looking at all the imaging data and then all of the measurement data and also the report data and putting it all together. And, because I've done echo a long time, I'm automatically thinking in phenotypes. It's just how I can't unthink that way, it's just automatic to me now. And that phenotype thinking is really to replicate the way I think into a presentation on the screen of what the data shows based on AI. And really, it's trying to get the phenotype to automatically present to assist me and improve the quality of my reporting.
Great. You use the term phenotype, and we know that in aortic stenosis, patients have traditionally been considered for valve replacement once they meet guidelines for severe disease.
Mm-hmm.
How does phenotype thinking, or the role of the phenotype for severe aortic stenosis, particularly as we've developed it at Echo IQ using artificial intelligence, how does that change things?
Yeah, it does actually. So the way that we know the disease of aortic stenosis happens is not just about the valve. Okay, so we've got a narrowed valve, calcified, decreased motion of the valve leaflets, increased velocity of blood across there. But that's not the only thing that happens in aortic stenosis. And as a cardiologist, that's not all I'm looking at. What I'm looking at is, the ejection fraction, whether I'm looking at impaired forward stroke volume, I'm looking at the ventricular wall thickness, ventricular mass, looking at things like the septal prime velocity, lateral prime velocity, average, the abnormal relaxation of the ventricle, increase in filling pressures, increased air to E prime ratio, looking at the left atrial volume. Is there that diastolic dysfunction type of impaired filling patterns, so increased left atrial volume and pulmonary hypertension, and possibly, in fact, if you think of it from a cardiac damage point of view, possibly even right-sided changes. And so, moving on even further, more sort of myocardial disease, then moving into RV damage, pulmonary hypertension, and evidence of tricuspid regurgitation. So, like taking the whole sequence together. Then that's how I think when I'm looking at aortic stenosis in trying to make a decision on not just the severity of the valve, but the severity of the syndrome. And that's what our EchoSolve is designed to do. It takes not only the data of the velocity across the aortic valve, but takes all of those ventricular parameters, the ventricular diastolic dysfunction, ventricular systolic dysfunction, increase in filling pressures, and translation of that to pulmonary circulation and the right-sided valves. One of the tricks, though, that we as clinicians often see as a mistake or an error in measurement is related to the LVOT. Okay, so an error in the LVOT dimension because of the continuity equation is multiplied and squared in the calculation of the aortic valve area, and an underestimation of the LVOT velocity.
Yep.
Also gets multiplied and squared because of the same problem with the continuity equation. So I'm actively looking for that. And does that less than 1 square centimeter aortic valve area mean that they've got severe AS? Or does it mean that there's been a measurement error somewhere? The designer of the EchoSolve AS product is designed to get rid of that problem because the AI specifically excludes that. There is no LVOT data in there. So it specifically excludes LVOT dimension, LVOT velocity, LVOT BTI, anything to do with the LVOT, basically. So that the AI is made to look at the aortic velocities across the aortic valve and the rest of the echo,
Yep.
Which basically means that the AI is kind of one arm behind its back predicting what the phenotype abnormality is. So it goes back to where we started from. The way I think about aortic stenosis is looking at the phenotype, and the aortic stenosis AI has been designed to think about the phenotype and present that data back as well.
Terrific. Thank you. We know that there are certain cases of aortic stenosis that can be notoriously difficult to identify. Do you see EchoSolve AS in helping to address those cases?
Yeah, so one of the hardest ones is when you see a decrease in the LVOT velocity and a decrease of the aortic velocities, but the aortic valve area is less than 1 square centimeter. So in other words, AVA comes into the severe category, but the gradients aren't saying severe.
Yep.
Then we've got this potential challenge of, is it a measurement error, or is it truly severe but low gradient AS? This is where I think the AI is particularly useful, because it picks up, as we were talking a moment ago, about the phenotype of risk that we're trying to identify. Every one of those echo parameters that change in response, then they're going to be abnormal too. In the setting of low gradient AS, then you've got, sure, the velocity and the gradient don't meet the classic definition of severe, but all these other changes are the reason it doesn't meet severe. So there's a decrease in the forward cardiac output, which means that they're not generating the high gradient. And that's where the EchoSolve is great, because it comes up, it's red, it's saying high risk phenotype.
Yep.
Then you go back and look at the echo and say, okay, that makes sense, right?
Sure.
Because it's, the echo is abnormal because of all of these classic changes that occur. They're not generating the forward cardiac output. That's why the gradients are low. And so that's a real severe aortic stenosis, as opposed to a measurement error, apparently severe aortic stenosis.
Great, thank you. Would there be situations where you might not report what EchoSolve reaches as its conclusion?
So in aortic stenosis is a good example. EchoSolve is looking at the whole phenotype. So it's looking at all of the data together. There are times when I know something that the EchoSolve doesn't know. So here's an example. Somebody's had an aortic valve replacement. Let's say they've got a subdued mechanical aortic valve replacement. They've got some mildly impaired valvular hemodynamics. We're aware of it, okay? It's a known condition. So EchoSolve will probably come up with red as in, high-risk phenotype.
Sure.
But we already know that, because that's somebody we're monitoring with that disease. So I won't necessarily be flagging that as this person has a new clinical state, so I suppose everything's in context. Yeah. But on the other hand, if somebody had let's say, even though it's not indicated for valve replacement, but as a clinical decision support tool, if I saw a state flagged up that I was not expecting, and I look at that more closely and think, wow, actually the AI has found something that I hadn't actually necessarily anticipated would be there, then that can just change my decision-making the other way once I go back and review it. But remember, this is a clinical decision support tool. It's not intended to say you always have to do exactly what the AI says. Mm-hmm. The AI is alerting you to look more closely. Yeah. And looking more closely means that you may actually look more closely and decide one way, or you may look more closely and actually decide the other way. Yep. So I think it's very useful in that scenario. But I think the thing to highlight is that, in general terms, it's not the exception that we're looking for. It's the rule that's the most likely to happen. And the rule is that most of the time, the EchoSolve AS identifies the state, the high-risk state associated with the severe aortic stenosis phenotype. And that's people with native aortic valves as opposed to aortic valve replacements. And the really clever thing is the ability to identify those with the low flow states, the lower gradients, but still have that same high risk.
Right.